So there are a lot of issues with polycystic ovarian syndrome, or PCOS. About 75% of my patients experience that.
Is infertility hereditary?
Components of it can be. There's a condition called premature ovarian insufficiency, which is a condition whereby people go into early menopause.
How common is miscarriage?
Anywhere between 30 to 40% of pregnancies can result in loss. There can be investigations done for both the egg and the sperm providing person. The sperm can be just as much a part of the problem.
Is a person truly considered high risk if they choose to have a baby after 35?
We have to consider the fact that the quality of the eggs, quality of the sperm can be different past 35.
I think I've seen it somewhere about how taking contraceptives can affect your chances of having a baby. Hi guys, welcome to the podcast. First, let me give you a little backstory. Radio program as a tool for adopting maternal healthcare practice amongst women of reproductive age. That was my thesis in college. I remember it like it was just yesterday, and I graduated about 9 years ago. So I've been interested in women's health since forever. Unfortunately, I couldn't be a doctor, but I have questions, and every time I get the opportunity to speak to somebody who actually knows things about women's health, reproductive, fertility, I'm always super excited. And my guest today is just that. Guys, I cannot wait to dive into this conversation. Let's go. Hi guys, so before we get into the episode, I have a little huge favor to ask of you. Over the years, I've learned that closed mouths don't get fed. So this is me opening my mouth with the hopes that you'll feed me to stupor. If you as little as enjoyed this show, please like, share, and subscribe. It gives me the extra motivation that I need to keep going because I really want to be doing this for a very, very long time. Okay, thank you. Let's get back to the show. Rachel.
Hi.
Hi. You look gorgeous.
Oh, thank you.
And
So
thank
do
you for coming on the show. Thank you.
Of course, thanks for having me.
Yes. So I like to do this thing where if I'm not sure, I have an idea, I've done my research, but it's still new, right? If I have an unsure knowledge, so to say, about everything that my guest does, I like to do this thing where I just ask them to introduce themselves.
Sure.
So what do you do?
What do I do? Oh, goodness. So I'm a fertility-focused naturopathic doctor. So I practice within a fertility clinic here in Ontario. So my Monday to Friday, 7 to 3 generally, is taking care of people who are trying to conceive. And I'm helping them really improve and optimize their preconception healthcare. And I work with patients who are just at the beginning of their fertility journey. They may have just started to think about wanting to try to conceive, all the way through to patients who are, years into very difficult fertility journeys, and everything in between, right? I also help patients once they become pregnant to be healthy and well during their pregnancies. And then I will offer them care postpartum as well, so that they can feel their best while they're entering their new phase of life as a parent.
Yeah. So what is a naturopathic doctor for somebody who doesn't know?
Yeah, so good question. So here in Ontario, naturopathic doctors are essentially part of the primary care system, but in a different way. So where, you might visit your primary care physician, like your general family doctor, and come in with your complaint and be perhaps prescribed a medication. When you're working with a naturopathic doctor, we're looking at the issue from a different perspective. And generally, we're trying to get to the root cause of the issue. And instead of being trained to provide, prescriptions, which we can for some things, we're really working on overall wellness. So we are working on nutrition, we are working on lifestyle factors, we're using, in some cases, supplements, nutraceuticals, botanical medicines, and also working on improving, overall health in order to help patients achieve their wellness. So in the fertility world, this is very important because, as I like to say, when we're working to build a whole other human, we have to make sure that we as humans are well to begin with.
So you're saying that the things that I eat and the lifestyle that I live could affect the chances of me having a baby?
Absolutely. And it's something I see day in and day out.
Interesting. So why this? Why this profession?
Great question. So I grew up in a household where health was, and I should say wellness, was a priority.
Yeah.
My mother always, cooked very healthy meals. My father at the time was an Ironman and would compete in competitions for, running and swimming and biking. And so exercise was always a big focus in our house. My parents divorced when I was 16, and my mother at that time became a bodybuilder, believe it or not. And so that took, the understanding of fitness and nutrition to a whole new level in my household. And so during my childhood, I also grew up being very involved in sports and eventually in dance. And so I just became very interested in the human body, in taking care of it. In my house, if you had a headache, you probably didn't drink enough water or you needed to go and take a walk.
Sounds like my husband.
Oh, yeah?
Yeah. Every time I'm about to take my Tylenol, he's like, no, just drink water.
Right? Like there may be something going on, right?
Yeah.
So that was the approach in my house. And so when I decided, to go to university, I was actually deciding between journalism and, kinesiology at the time. And I decided on kinesiology, and I just dove right in and was so fascinated about anatomy and physiology and just understanding the movement of the body. But, at the time when I was in school and sort of coming to the end of school, I was starting to develop some of my own health issues.
Yeah.
And I wound up not having a period for a year.
Oh, wow.
And so I went to the University Health Clinic, and at the time I was a student at the University of Western Ontario in London. And the doctor at the clinic said to me, well, you have a lazy ovary, and good luck to you when you want to have kids. It's going to be a real struggle. And that was kind of shocking to hear in my early 20s. It's not really information that I was expecting.
Did he say it like that?
He said it just like that.
Wow.
And sent me on his way. Or sent me off on my way. And so I thought, okay, this is interesting. And it just so happened that when I received that information, it was at the time that I was starting to figure out about my next steps. Because unfortunately, with a kinesiology degree, Bachelor of Science, there's not a ton that you can go directly into after that.
Yeah.
So you're often going into another stage of education, right? So perhaps you're becoming a teacher, perhaps you're becoming a physiotherapist, medical doctor, chiropractor, so many different avenues that you can go. And it just so happened at the time there was a career fair at Western, and I came across naturopathic medicine. And I thought, what's this all about? And so I decided to really do my research, and I took my fourth year of school to do a thesis paper on the history of naturopathic medicine in Canada. I started working with a naturopathic doctor in the area for my own health issues, and it was really just this kind of awakening for me where I was like, wow, I had no idea this existed as a field of study or as a career option, and it just felt very right. And I've really never looked back from there.
Yeah.
And so I went ahead and did my training. I started at the National College of Natural Medicine in Portland, Oregon, and then I transferred back to Toronto, which is where I'm based, really. My family is based out of Ontario, and I finished my education at the Canadian College of Naturopathic Medicine, and I've been in practice now since 2014. So almost 11 years.
Wow, interesting.
Yeah, yeah, it's been quite the journey.
So in your experience now over the years, what has been, or what do you think is the major cause of infertility in women? Yeah.
So that's a great question. It's varied.
Okay.
When I think about the, people who come into my clinic who are having issues struggling with fertility, I tend to see trends in what people are experiencing. So there are a lot of issues with polycystic ovarian syndrome, or PCOS.
Okay.
That's very common in infertility. About 75% of my patients experience that.
Wow.
There are issues with thyroid, so thyroid issues impacting the ability to conceive.
Really?
Yeah, that's a big one for sure. We see issues with conditions like endometriosis
Yeah.
as a factor. And, you know, a lot of these conditions are things that can be very well managed if we are taking good care of ourselves. And unfortunately, I see that a lot of my patients don't.
Yeah. So two things now. For somebody who doesn't have an idea, I've heard these things. I even know like a couple of, people who battle with it personally, and that's PCOS and the endo word.
Yeah.
I always mix it up, so I just call
Okay.
it the endo one.
Yeah.
I think I should just learn it today.
Endometriosis.
Endometriosis.
You got it.
Endometriosis. So now let's define what endometriosis is for people who don't understand, and then PCOS.
Okay. So endometriosis is a condition whereby endometrial-like tissue, okay, so the tissue that is supposed to grow on the inside of your uterus, okay, that kind of grows throughout the month, and then if there is no pregnancy, is shed with a period.
Yeah.
That type of tissue grows outside of the uterus. So we can see it growing into the ovaries, on the fallopian tubes. We can see it growing onto different parts of the pelvic organs, causing adhesions where, the uterus can become stuck to the bowel. It's quite it's a difficult condition for sure.
Wow.
Yeah, and then polycystic ovarian syndrome, or PCOS, is a condition whereby the follicles within the ovaries that contain the immature eggs, okay, those follicles and the eggs inside are not able to mature properly. And so they get stuck in their immature state, okay? And it causes issues with anovulation, so not able to ovulate, okay? Which can thereby impact your ability to conceive. If you can't ovulate, then it's going to be really difficult to get pregnant.
What are the causes?
So if we're talking about endometriosis, the cause of endometriosis is not extremely well understood.
Okay.
It is sort of universally understood to be a very inflammatory condition, so it causes a lot of inflammation in the body, a lot of unrest in the body, but the real root cause of it is not well understood. So there are theories out there. For example, one of the theories with endometriosis is something called retrograde menstruation.
Okay.
So rather than fully eliminating the uterine lining during a period, some of the uterine lining actually stays and can cause essentially an immune system reaction and subsequent inflammation that causes this endometrial-like tissue to grow in other parts of the body. So that's one theory. With polycystic ovarian syndrome, there is often a root cause of something called insulin resistance, okay, or essentially blood sugar dysregulation, okay? And so that will cause an elevation in hormones called androgens, which are essentially male factor hormones.
Okay.
But, females or people who have eggs, we tend to have those hormones within us too. We have them in smaller amounts. Yeah. When PCOS occurs because of insulin resistance, what happens is that dysregulation of blood sugar causes insulin levels to be very high. That causes androgen levels to be very high. And then that confuses the body. Yeah. Okay. And the ovulation process gets shut off. Yeah. Wow. I know.
It's a whole lot.
It's a lot. And it's really, it's interesting because a lot of people will come in with these conditions and they have absolutely no idea what's going on with them.
No symptoms?
Sometimes, right? So in the case of endometriosis, oftentimes people will have been dealing with very heavy, very painful periods for years and years. And, they've been told for a very long time, oh, that's just a period. That's just what it is. Just deal with it. Here's a prescription for pain medication. Off you go, right? Mm-hmm. And we really don't start to dive into, could this be endometriosis until we're getting into the fertility years and we're starting to care about, oh, what's going on with my uterus, what's going on with my eggs, right, with my ovaries. And it's, similar with PCOS, oftentimes there are symptoms. So for a lot of people who struggle with that experience, they may not get regular periods, right, because that ovulatory experience is kind of shut off. They may not get periods, right? They may start to notice other issues. For example, they'll have, because of the high androgens in the body, they'll start to present symptoms of high androgens. So if we think about, androgens, males tend to have a lot of androgens. What do males have? Facial hair, right? Sometimes they lose the hair on their heads, right? So those types of symptoms can start to develop in females, right? So those are some of the things that people might be dealing with and not know what exactly it is that's going on.
Wow.
Until they start to really think about trying to get pregnant.
Are there any symptoms for PCOS?
Yeah, so that would be it. As I was
Same
saying,
thing.
with the PCOS, it's the irregular periods, and then we'll start to get these signs of, we call it like hyperandrogenism or androgenic signs, where there can be the facial hair.
So it's the same thing for both?
No, so sorry to clarify there. So with PCOS, it'll be the irregular periods, it'll be those androgenic signs, hair growth on the face and body, acne, hair loss from the head, things like that, difficulty with weight management. With endometriosis, the main symptom tends to be very painful and heavy periods.
So are painful periods generally a cause for alarm?
It depends on the degree of pain, right? And it depends on the type of pain. So when we think about what a period is, a period is the shedding of the uterine lining, right? That's going to come with a slight degree of discomfort. Is it supposed to be extremely painful? Absolutely not. So one thing that I'll ask my patients is, okay, so what is your period like in terms of pain? Like when you tell me you have cramps, is it a 1 out of 10? Is it a 10 out of 10? Is it a 12 out of 10? Where are we on this pain scale? And that can give us an idea if there may be something unusual going on, right? And so if I have patients who are telling me that they're doubled over in pain every time they get a period, they have to miss school, they have to miss work, they're vomiting because of their pain, they can't live without their pain meds, they're in so much pain, then of course my alarm bells are going off that this is not normal. That is not what a period is supposed to be like.
Really?
Yes.
Because what's interesting is I used to actually have one of those like really, really bad periods until I got married and I had a baby. And then it's still like, now it's like every time I have it, it's like a 3 out of 10.
Yeah.
But in the past, it used to be like a 10.
Yeah.
Out of 10. Like I used to throw up. I had to use my meds.
Oh, I'm so sorry.
Yeah.
And there can be other causes of period pain besides endometriosis. Fibroids can be a reason for pain. Polyps can be a reason for pain.
What are those?
Those are other growths that can develop in the uterus. They're benign growths typically, meaning that they're non-cancerous growths typically. But those types of things can cause painful periods. There's another condition called adenomyosis, which is like a sister or like a cousin of endometriosis, whereby instead of that uterine lining tissue growing outside the uterus, it actually grows into the muscle wall of the uterus. And that can cause pain too. So there's a variety of different reasons why painful periods can occur. But 10 out of 10 pain, that's not normal.
But it's stopped.
Going on. Yeah, and that's the interesting thing about, getting pregnant and having a child, delivering. You're almost like this whole new body afterwards, right? I'll use the example of patients at the fertility clinic. Once they've conceived and they've delivered, and let's say they're thinking about having another child, they have to go through all of their workup again. Right? It's as if they're a whole new person, right? They need to go through all of their hormone testing and their imaging studies, and we need to understand, well, who are you now, right? Because things can absolutely change after you've had a pregnancy.
So what is the role of the man in female fertility? Right,
okay. So if we're talking about the person providing sperm, it's a 50-50 thing, right? And I think that's something that isn't always fully understood,
Okay.
that sperm health plays an enormous role in the likelihood of conceiving, and also in the health of a pregnancy, and also in the health of the children, right, after delivery.
Yeah.
So it's a huge factor. And, I think, for females or for people who are, bringing the eggs to the equation, the thought is often, well, it's all on me.
Yeah.
Right. And I see that time and time again in practice where, the female partner will often put a lot of blame on themselves or take all of the responsibility on themselves. And it's not fair, because I will say in a large majority of the cases that I take care of, the sperm is just as much as an issue, as what's going on for, the person who has the eggs. Yeah, so it's very important to have healthy sperm, right?
It is.
Oh yeah,
Yeah.
absolutely. And unfortunately, I see a lot of really not great sperm.
Yeah.
Yeah.
But then we don't talk about those. We just make it seem like it's the fault of the woman.
That can often be the case,
Yeah.
right? But I will say, in my experience, and certainly with the fertility clinic that I'm a part of, the person who's bringing, the sperm to the equation has to go through testing as well. We have to know what's going on with the partner's sperm quality. We need to know what's going on with the partner's hormone health. In my case, I'm also diving into what's going on with their metabolic health, what's going on with their nutrient levels, right? What's going on with their overall wellness, so that we know that we're bringing good ingredients to the equation when we're talking about making an embryo.
Yeah. So can you have PCOS and endometriosis? Did I get it?
You got it.
Okay. And still have a baby?
Yeah, you can.
Yeah?
I've seen it happen.
So we have cures for the conditions?
Cures is a big word,
Okay.
right? If we talk about those conditions, oftentimes it's management. How can we manage these conditions so that we can achieve our ultimate goal, right? Which is conceiving and maintaining a healthy pregnancy. So it can take time. It can take a lot of different team members, right?
Yeah.
And it can sometimes be a bit of a struggle, but once we get the formula right, once we figure out exactly what that person needs, we can absolutely achieve the goal of pregnancy. What I think is important is understanding that if those conditions are in play, that we need to be prepared for it to potentially take a little longer than we, think it might take. And that it's important to kind of think ahead, right? So I find for a lot of people, when they're thinking about, growing their family or starting their family, they may not actually think that hard about it, right? They're like, oh, well, I got married, I'll come off the pill, now let's go make a baby, right? And this will happen in a month or two, right?
Yeah.
And it's really not, it's not like that for
a
lot of people. And that's also not entirely fair. Most of us take about a year to plan our weddings.
Yeah.
Why wouldn't we take about a year to think about, building a human?
Yeah.
Something that's, going to last a whole heck of a lot longer than a day.
Yeah.
Right? Like, we're talking about an entire life that we're creating. Why wouldn't we take steps to ensure that we're going to make the best life that we can for that person, right? So that's where the preconception element comes in, and making sure that your preconception health is top notch.
Yeah, so for such women, do they have like normal pregnancy journeys, or it's difficult for them? It's more difficult than the
Good question. Yeah. So let's talk about PCOS first.
Yeah.
Right? Because in the case, like I said, of a lot of polycystic ovarian patients, the root cause of that is this blood sugar dysregulation, or this insulin resistance, right? If we think about blood sugar dysregulation, a lot of people may think about diabetes, for example, right? That's another example of blood sugar dysregulation.
Yeah.
So unfortunately, if people have PCOS, it does put them at a higher risk of developing gestational diabetes. So diabetes during pregnancy.
Wow.
Yeah. right? So they're going into a pregnancy with blood sugar dysregulation. So it's, natural, then that could potentially worsen whilst they're pregnant.
Yeah.
So that's something that we discuss with patients, right? Like, we're going to try to get this managed before you go into a pregnancy so that we can potentially avoid you having gestational diabetes during pregnancy, right? Because that can be a complication that can then go on to cause other issues, right? Sometimes we can see that leading into issues with blood pressure, right? Hypertension of pregnancy or developing preeclampsia, right? And then those are both conditions that can impact delivery and the safety of
What are
delivery.
preeclampsia?
Preeclampsia?
Yeah.
So preeclampsia is a condition where blood pressure has gotten so high during pregnancy that it's starting to impact organ function within the body.
Wow.
Yeah, I actually had that experience with the delivery with my daughter.
Yeah.
It was because I had issues with my placenta. My placenta was not healthy.
No?
No, unfortunately. So it can develop, preeclampsia can develop for a variety of reasons. But if we're talking specifically about PCOS, certainly gestational diabetes can be something that is related to the development of preeclampsia as well. So that's PCOS.
PCOS, yeah.
Yeah, endometriosis. It's an interesting question about if it makes for a more complicated pregnancy. Sometimes I would say that the risky part is during the initial stages of the pregnancy and whether or not we're going to be able to see that person be able to stay pregnant, right? So in some cases, we'll see that patients who have had endometriosis can have a higher risk of losing the pregnancy. Yeah, so, and that's a whole other conversation, right? Recurrent pregnancy loss is a topic, entirely in and of itself. It's certainly one that has been in my office a lot this week.
Yeah.
Yeah.
I mean, we're going to touch base a little bit on that, but before we move further, I wanted to ask, and don't quote me on this, but I think I've seen it somewhere about how taking contraceptives can affect your chances of having a baby if you finally decide to get off the pill.
That's a multifaceted question to answer in a way, because in some cases we can see that, the pill can quiet hormones down a little bit. So for some people that can actually provide a benefit prior to becoming pregnant. So for example, I'll go back to PCOS again. So with PCOS, some people will actually find that if they've used a hormonal contraceptive and they come off of it, their chances of conceiving are actually greater 3 months after stopping the contraceptive.
Interesting.
And it's because it's really minimized those androgens that we talked about.
Yeah.
And so that they're more likely to ovulate.
Wow.
So in some cases, right, the hormonal contraceptive can certainly serve a purpose. I think where it can be problematic is if we're using the contraceptive for, a period issue that we're not really getting to the root of, right? So for example, if it's like a painful period and we say, okay, we'll take the pill, it'll make it better. Okay, but what's causing that painful period? Maybe we should figure out what that is so that we understand, right? So I would say that's more of it. And one other thing that I find to be challenging is, we use the contraceptive in some cases to, shut things off. We don't want a period, just make it go away. I don't want to deal with it. And then we come to the point in our lives where we want to have children and we have absolutely no idea what, the hormones are all about and how that process works. So we have to do all of this education again for people about what a menstrual cycle is and, all that stuff that they didn't want to learn about in grade school.
Yeah.
And now they're, 20s, 30s, and they're thinking about having kids and they're like, what was that again? And they're, scrounging on the internet to figure out what it is and what's normal and who do I trust? And, we have to, it's just, we've shut that off. And we need to think about maybe learning what that is and what it's all about again.
Wow.
Yeah.
Yeah. Okay. So there's infertility.
Yes.
And then there's secondary infertility.
Yes.
Right?
Yeah.
I think I know a couple of people, like one or two of my friends, they've had like one or two kids,
Yep.
and then they try to have another kid, and then nothing.
Yep.
What could be the cause of that?
So many different causes. So
Yeah.
you're right in your terminology. So if we're talking about what primary infertility is, that's someone who has never been able to conceive.
Yeah.
And we're looking at a window of over 12 months, or 12 months or greater if they are under 35, and 6 months or greater if they are over 35. So that would be primary infertility.
Yeah.
Secondary infertility is where they have had a child already. They have successfully conceived already, and now they cannot conceive again within those same time parameters. And so, because you think to yourself, well, I did it before, I should be able to do it again. Like, what the heck's going on? But like I said, in a lot of cases, we're dealing with a whole new person, right? So we have to investigate, well, what could be going on? Are there issues with ovarian reserve? Maybe we're starting to run out of eggs, right? Are there issues with the quality of the eggs, right? Is this person over 35? Do we need to start to really work on the egg quality component? Is there an issue with their hormone balance? Like I mentioned, the thyroid, is that part of it? Is there a dysregulation there? Are we having issues with progesterone production? Is there an issue with, the uterine cavity? Did something happen during pregnancy or delivery with the first child that would have impacted, the uterus, the fallopian tubes, the ovaries, right? So there are so many different components that happen there. And then if we think about the partner, the sperm providing partner, have things changed for that person, right? Maybe the parenting was really stressful the first child and they stopped taking care of themselves. They're eating poorly, they're not exercising, they've taken up, having too much alcohol. Marijuana,
Really?
right? Legal here in Canada, hugely impactful for sperm quality, right?
It's good?
Not good.
Not good, okay.
Not
Had
good.
to clarify, yeah. Wow.
Public service announcement. Marijuana is not great for sperm.
Wow.
Yeah. So, there are so many different factors that can impact secondary infertility issues. And so we have to investigate it just as we would any other person coming in who isn't able to conceive.
So is a person truly considered high risk if they choose to have a baby after 35?
High risk, not necessarily.
Yeah.
Do we have to be more mindful of certain things? Yes.
Okay.
I think geriatric is a very outdated term. Certainly advanced maternal age is something we talk about. And so we have to consider the fact that the quality of the eggs, and in some cases, quality of the sperm can be different past 35. When we're talking about what that quality, what is the quality issue, what we're often referencing is the mitochondria within the eggs and the sperm. So that's the engine within the eggs and the sperm. And then the genetic material, the DNA within the eggs and the sperm, right? And so, let's think about it, right? If you had a 35-year-old car with a 35-year-old engine, would we just expect that car to function beautifully and that engine to function beautifully? Not really, right? It's 35 years old. It's going to need a little bit of extra love and attention.
Yeah.
So that's what I'll often explain to my patients is, if you're over 35, your engines have been around for a while. I need to really make sure that they're good quality engines. Let's talk about things we can bring in, like coenzyme Q10. It's kind of like a little oil change for your engine, right? It's an antioxidant too. It's going to help improve the genetic material, right? So it's those components though that can make it more difficult to get pregnant past 35. And can also make it more difficult to maintain a pregnancy past 35, and then can put you at risk of issues with the pregnancy.
There's so much.
There's a lot.
Yeah.
There's a lot. There is, right? And it can be scary and overwhelming, but I think the moral of the story is there are people to help, right?
Yeah.
This is my all day, every day. This is what I talk about with my patients, 365 days a year, it feels like. I do take some vacations.
Yeah.
But, there are answers and there are things that we can do, and we don't have to put our heads in the sand about it, right?
Yeah.
Right? And we don't have to, I find like everyone goes to the internet first.
Yeah.
Right? We were talking about ChatGPT earlier. Everybody's going to go to ChatGPT
and ask. ChatGPT is actually helpful.
Yeah,
it
100%.
can be. Yeah.
It can be. But here's the thing, and I borrow this phrase from Katie Couric, who is a journalist in the US. She coined this great term, which is TMI NEU. Okay, and I'm borrowing it today. Too much information, not enough understanding. Right? So, I mean, it's no different. I'm going to go to ChatGPT and ask a question. I'm going to get a whole bunch of information. It's the same with Google.
Google is worse.
For sure.
Google doesn't filter nothing. You could go for a headache. It'll tell you have cancer of the brain.
Oh, 100%.
Google is so scary.
Yeah. But we have to be able to interpret that information, and that's where I think the tricky part comes in, right? We can't always understand what we're being told with some of these services, and so it's important to get the proper team members in place to be able to understand what's going on with your particular fertility situation. Yeah.
So if somebody came to you now and is like, oh my God, Dr. Rachel, I need your help. I've been trying to have a baby for the past how many years and it's not been working. What would be the first step of advice, or what would be the first set of questions that you would ask them?
Yeah, great question. So question number one would be, of course, just having a general understanding of their medical background, right? I need to know, what are we dealing with here, right? Do you have medical conditions? Are you taking medications? What's your surgical history? What supplements are you using? What's your period like? Let's talk about that. When are you timing intercourse? Right? Do we have that right? That in and of itself is tricky for people because they rely on apps to tell them when they're ovulating. Okay, those apps are based on an algorithm.
I mean, sometimes I know too, like your body tells you if you listen.
It does.
It's kind of like a mini cramp at the side of my tummy sometimes. And then some of the discharge, which we will get to. But I know.
Yeah, but a lot of people don't. They've never noticed those things before, right? And so they're looking at their apps going, oh, well, my app tells me it's this day. And we could be missing it altogether if we're not paying attention to some of those other body signs, right? Then we're going to start to talk about what's going on with their nutrition, with their weight management, with their exercise, with their stress, with their sleep, with their digestion, right?
With my sleep.
Sleep can impact things.
Really?
Yeah.
I mean, I know sleep is good, but to affect infertility? Your fertility rather? Yeah.
Yeah, I mean, I wouldn't say it's like the crux of the issue.
Yeah.
Right?
It can be.
It can be contributing though if we consider how much repair happens during sleep and how important sleep is for our circadian rhythms, right? Just our normal daily rhythms.
Yeah.
And if we think about it, you and I as females, as people who have eggs, we're on, I'm going to put this in quotations because it isn't always the case for everybody, but we're on a 28-day cycle, right? Things are different every day of those 28 days. So those rhythms become really important. So if our sleep rhythm is off, it can throw off our other rhythms too. So we'll see that, for example, in shift workers, right?
Yeah.
Like I have a lot of patients who are nurses and they're working shifts in the hospital. And, when they have night shifts, or a lot of night shifts, we can see that impacting what's going on with their cycle regularity, right? So there is a component of sleep that's impactful for sure. Melatonin, which is the hormone that helps us get to sleep, is an antioxidant.
Yeah.
So it can be very beneficial for egg quality. So if we're in front of our phones and our screens late at night, and we're getting all of that blue light exposure, we're really minimizing our melatonin production, and then that can impact egg quality in some cases. Yeah, so there are, factors that are important there. We have to think about it in a very holistic way.
Yeah.
And then we're going to really get started on pretty robust testing, right? Hormone testing, nutrient testing. We'll want to have a sense of what's going on with imaging, right? Ultrasound and that type of thing. Sperm analysis if they have a partner. So there's a lot that we look into to understand what's going on.
Makes sense.
Yeah.
Is infertility hereditary?
Components of it can be, for sure, right?
Yeah.
So, yeah, and that's a bit of a robust question as well. I'll perhaps give some examples. So, there's a condition called premature ovarian insufficiency, which is a condition whereby people go into early menopause, essentially. And it's because they don't have a lot of eggs.
How early are we talking about?
Well, it can vary, but generally it's below 40.
Wow.
So in some cases of that particular condition, there can be a genetic cause that was inherited. We can see, I've seen, in some cases we can see that with the partner that's providing sperm. There can be inherited conditions that can impact the ability to produce sperm, right? So some of these things can be inherited. We can also have conditions where, the genes are there, right? So we talk about something like PCOS.
Yeah.
There may be a genetic predisposition towards diabetes.
Yeah.
And so then that puts that person at a higher risk of developing PCOS. So there can be inherited components to different levels of severity.
Wow. So now let's talk about the stages, or like the feelings that you go throughout your cycle as a woman.
Love
right?
that. Love
right?
that.
Because I don't know everything, but I know that 1 week before my period comes, every time I go to the gym and I'm not able to do like my complete sets, or I'm just like thinking about my life and thinking, oh my God, I'm at the right place and I'm just tired. Like whenever I start to get those feelings, I know my period is coming like the week before, the week after, right? But that's the only thing I know.
Yeah.
So can you break it down and then explain? Yeah.
And first of all, props to you for exercising, right?
Yay.
Because me just trying to get my patients to exercise some days is like my life struggle. So I'm glad you're doing that. So let's talk about the menstrual cycle. I love to talk about the menstrual cycle.
Yeah.
I have a whole course about this
Yes?
because I noticed with a lot of my patients who were coming into the clinic that they just didn't have this basic information. So I was like, we need to step back and start with the basics, right? So let's talk about what happens. So at the beginning of the menstrual cycle, okay, we are in a situation where the uterine lining is shedding. Okay, so that lining that was built up to hopefully support a pregnancy, right? There isn't a pregnancy there. So the body goes, okay, let's reset. Let's shed that lining.
Okay.
What happens right before that is because the body has recognized that there isn't a pregnancy present, hormones start to decline. Okay. Progesterone and estrogen being those main two hormones. They start to decline. The body goes, okay, let's reset. And we start to shed the lining. Okay? So that's what's happening at the uterine level. The lining shedding, we have a period, right? What's kind of going on behind the scenes is that the brain is starting to send a message down to the ovary. Well, we got to try again. So the brain will send a message down to the ovary via a hormone called FSH, or follicle stimulating hormone. And that hormone's job is to get a follicle stimulated, okay? A follicle, as I said before, is basically like a sac, and there's an egg that lives inside that sac. Not every follicle has an egg inside, but most of them do. And so when we start to stimulate that follicle with FSH, the follicle is going to start to mature. Okay? So that maturation process, we have testosterone converting into estrogen while that follicle matures. Okay, so now our estrogen level is going up. What's happening down at the uterine lining? We've stopped the period's done, right? We've got more estrogen. The uterine lining is starting to grow up again. We're also starting to stimulate the cervix. The cervix has these little pockets in it called crypts. Okay, those.
Did you say crypts?
Crypts.
Okay.
Yeah. Those crypts create mucus. So as the follicle starts to mature, and as the uterine lining starts to grow, the cervix is starting to get stimulated, and we start to see changes in discharge. Right? So what do we start to see? Well, usually just after the period, there's no discharge. It's a little bit dry.
Yeah.
Then we might start to see like a stickier discharge developing,
Yeah.
right? That means estrogen levels aren't too high yet, but they're starting to build. Then we'll start to see like a creamy or a lotiony discharge.
Yeah.
That means estrogen levels are climbing, okay? And then we'll see that like egg white discharge, right? Like the stretchy,
Yeah.
sometimes clear,
Yeah.
clearish, shiny discharge. That means that that follicle has gotten quite mature.
Okay.
The estrogen levels are high.
Yeah.
We're just about to ovulate.
Yeah.
Okay.
Okay.
So that's a great time to try to conceive because sperm can hang out in the uterus waiting for an egg to arrive for up to 5 days.
Yeah.
Right? So the egg, once it's been ovulated, is only viable for about 24. So if we can have sperm there ahead of time,
Waiting for it.
waiting for it,
Yeah.
as it should, right? Why not?
Yeah.
And so that's a sign that our body gives us that we're close to ovulating, right? That stretchy
Yeah.
cervical mucus, okay? So that, when those estrogen levels climb up high enough, right, that'll trigger LH or luteinizing hormone, which is that hormone that we can measure on those ovulation predictor kits or the LH strips, right?
Yeah.
That will tell us if we're supposed to be ovulating,
Yeah.
right? That's that hormone that triggers ovulation,
Okay.
right? So we ovulate. Now an egg's been released. If there's sperm there, hopefully egg and sperm meet, and
Okay.
we have an embryo that's going to travel down the fallopian tube and nestle into the uterine lining, right? If not,
Yeah.
then we won't have that process happening. But what happens is that follicle that's burst open and released an egg,
Yeah.
it kind of retracts back into the ovary, and it turns into something called the corpus luteum. Okay? That produces progesterone. Progesterone is the hormone that's really important after you ovulate.
Okay.
It's going to take that uterine lining that we've grown
Yeah.
and it's going to make it juicy.
Okay.
Okay? But that's that hormone that sometimes can make you feel a little bit like down. Right? So right in the middle of we call it the luteal phase, corpus luteum,
Yeah.
right? Luteal phase.
Yeah.
So right at the middle of that, which is about a week out from your period, progesterone and estrogen will be at their highest levels in that phase.
Yeah.
And then they start to drop off if there isn't a pregnancy. So that's where that week before we start to feel those hormones starting to drop off. And that's where often people can start to feel a little bit symptomatic, right? They may be a little more tired. There may be a little bit, sometimes they can notice some mood changes, right? Maybe they're starting to develop some cravings. And then we can see worsening impacts from that, right? If we've got imbalances, headaches, breast tenderness, bloating, all of those types of things. Yeah. And then, like I said, if a pregnancy has occurred, then progesterone's going to keep going and, off we go, pregnant. If a pregnancy hasn't occurred, then those hormones drop off and we start the whole process again. Yep.
So you increase your chances of getting pregnant if you have sex a couple of days before you ovulate, because the sperm can live up until 5 days and you can just stay there waiting for the egg.
Just hanging out waiting. Yeah.
Interesting.
It is interesting because a lot of us will use those strips and go, oh, it's time.
Yeah.
I'm ovulating now, right? It can be helpful to try to just take a step back and look at the body signs too, right? So that we can make sure that we're getting sperm there ahead of time too.
I feel like I might have been a badass doctor if I decided to pursue this, because like one of my friends that was she's had a baby. Actually, two. There's a family friend of mine and then my friend. They've had babies and they were trying to have more babies and nothing. And so I gave the advice of try and have sex before you actually ovulate, because sometimes you might actually even miss the ovulation day thinking that So try and have it like a couple of, and it worked.
Yeah.
It worked for one of them.
Yeah.
I'll check up on the other one. It's not been 9 months yet. But it worked for one of them, and I'm a little proud of myself, I think.
You've got that intuitive knowledge there, right? About
I
the
do.
function.
And I've had this thing where I'm kind of like in tune with my body, right?
Perfect.
Like I know when stuff is going, like every time I've had 2 babies, right? And every time I get pregnant, I always know, because I always have like there's just this strong feeling at the left side of my tummy that is stronger than usual, right? And I just know that something is going on. I'm speaking about being pregnant and having babies. I also kind of wanted to talk about miscarriages,
Okay.
right? Because I feel like it's very common.
It is.
Yeah.
Yes.
But for some reason, I don't know, people don't talk about it. I miscarried my first pregnancy, for instance.
Me
I
too.
know, yeah? And I know at least 2 people who are close to me that have miscarried, right? So it's like, it's so common, but people don't talk about it much. Why do you think that is?
Oh, goodness. I think because as a society, I think we've gotten very closed off and very nuclear, right? We tend to really keep to ourselves and keep private. We don't live in these large villages as we used to in the past, and so we don't talk about these things, right? If we think about probably the last 100 years, there have been decades within that time period where a lot of these topics were taboo, right? There could be religious reasons, there could be cultural reasons why we don't discuss these things, right? And in a lot of cases, we just didn't necessarily have these platforms to discuss either, right? I mean, the whole concept of the internet and social media is still relatively new. I mean, I come from a time when there wasn't internet, right? Like the first 12 years of my life, the internet didn't really exist. So we didn't have these platforms to share. I also think that the prevalence of infertility and recurrent pregnancy loss or miscarriage has, worsened.
Yeah.
And so in the past, when people were trying to conceive, I don't think you were expected to not get pregnant. You weren't expected to have issues, right? So if you were having issues,
there was something
you wanted
wrong
to keep
with
it to yourself.
Yeah.
There's something wrong with you, right? Who do you talk to about this, right? So I think that there are probably a variety of reasons why people keep to themselves. What I found interesting about it as a practitioner in this area is how differently people experience loss.
Yeah.
So I've had my own experience with pregnancy loss, and I did find it quite devastating.
Yeah.
It was a terrible experience.
Yeah, it is.
Right?
It was.
Yeah.
Yeah.
But I've cared for patients who have not felt that way, who accept it in a very different way. And that's okay, right? I mean, we are all, welcome to our own feelings and thoughts and experience. It's going to be different for every single person, right? So for some people, I think they just don't want to talk about it because for them, it's not a big deal and they want to move on. Right? For others, they don't want to talk about it because it's been devastatingly painful.
Yeah.
Right? And so then there are others who want to talk about it because that's how they heal and move on. So I think, to be open about it
takes a lot. It can take a lot.
It can.
I feel like especially if maybe you've been trying for a while and then you finally get pregnant and then you lose it. It can be crazy. How common is miscarriage?
It's very common.
Yeah.
Yeah. I'm trying to think of like the most recent stats, but it's anywhere between 30 to 40% of pregnancies can result in loss.
Yeah, and I just want to talk about this because there's probably some woman somewhere who thinks that she's the problem or that something is wrong with her. Because I remember when mine happened and I was asking the doctor, okay, so what's the cause so that I know what to, and they couldn't even tell me what caused it because they don't know. You know, and I feel like it was particularly devastating because or like scary afterwards, because then when I got pregnant with my second baby, every doctor's appointment came with its own anxiety, because I didn't know what the result was going to be. And every time I share this story with somebody, they always ask me if the pain, how painful it is, and they try to compare it to labor. And I say, with labor, I have my baby, right? With this one, it's just pain. It's just pain with nothing to show for it. So it's just crazy, and I don't wish it on my worst enemy. So when we talk about things like this, is just so maybe somebody somewhere can see it and know that they're not alone.
Of course. Of course. But getting to the cause of it can be a difficult thing.
Yeah.
And certainly there are, conventional medical approaches to how deeply we investigate pregnancy loss.
Yeah.
Right? So, for example, if there has been one loss, that doesn't necessarily trigger a cascade of investigations. Oftentimes we're looking at 2 or 3 losses before we'll start to look into, well, why is this happening?
Yeah.
And then when we look at the reasons why a pregnancy loss can occur, I mean, the list is as long as my arm, right? Like when I'm working through a flow chart with a patient of what could be the reasons here, I mean, it's a long list of things that we have to consider.
Yeah.
And sometimes it takes time to crack what it is. But there are a lot of things we can look into. And so if we're getting to the point where it's happening repeatedly, there can be tests, there can be investigations done to understand what the heck is going on for both the egg and the sperm providing person, right? Because the sperm can be just as much a part of the problem.
So as a woman who intends to have a baby in the future, say I'm young, right? But I intend to have like a family someday. When should I start doing these checkups to know if I'm able to carry a baby and all this stuff like that? And then what type of checkups should I do? And should I also do any of these things with my partners?
Yes, great question. So I think the answer to that depends on where you are in your life journey, right? Because for the people who have the eggs, generally the female person, we do have to kind of think about that 35 timeline still, right? And so if you are someone who is 25 and you have a partner and you're thinking about trying to conceive, maybe we don't have to be as aggressive about our diagnostic testing as we might be for someone who is 32, doesn't have a partner yet, doesn't know if they're ready to try to conceive yet, but may want to in future, right? And maybe thinking about, do I need to freeze my eggs, right? So I would say, if you, probably to kind of average out somewhere, if you're sitting in and around the 30 mark and you're wondering, what is this going to look like for me? Do I want to have children at some point in my life?
Yeah.
That's probably a good time to start to do some investigations, just so that you can be informed, and empowered to make educated decisions about your body. And so in terms of things we can look at, we can get a sense of, what are your baseline hormones looking like, right? Do you have a good ovarian reserve? Are your, your hormones behaving as they should throughout the month? Is there anything structurally going on? So, even just some hormone testing and some imaging can be so informative and can help people make decisions about what they want to do, right? There's somebody like myself, I am someone with premature ovarian insufficiency.
Yeah.
I, am 40 years old now. I don't get periods anymore.
No?
Nope. They started to disappear for me after I stopped nursing my son.
Wow.
But I knew when I was in my very early 30s that was something that was going to be coming down the pipeline for me. So for me, waiting was not an option.
Yeah.
Right? So I think, it's a good time to really start to think about doing some investigations. If you're around that time of your life and you're not quite ready to start yet, then may as well take a look and learn and then decide.
Sounds like a stupid question, but I'll just ask.
Never any stupid questions.
So no periods means no babies, yeah?
I can't have babies anymore.
No?
No.
How did you deal with that though?
It was hard.
Yeah.
It's been a hard couple of years. And I would say one part of it that's hard is that it requires a lot of advocacy, right? It's not necessarily something that is well understood because it's not a very large part of the population who has this type of condition. So I have to do a lot of advocacy for myself with my healthcare providers to just remind them that, yes, I'm 40, but I kind of behave like a 50-year-old internally.
Yeah. Oh, wow.
Right? So being able to get the right type of care and, just to be on the right types of, hormones to support myself at this point in my life so that I don't develop osteoporosis, so that I don't,
What are those?
Osteoporosis is losing your bone density.
That can happen?
When your hormones start to decline as you get older, yes, that can be a contributing factor to osteoporosis. Cardiovascular health becomes an issue when your hormones start to decline. Cognitive health, right? There are so many factors. And, we live a lot longer these days, and we live a lot longer without hormones, right? Most people, if they're menstruating people, will stop menstruating by 50. Right? So, a lot of us are living well past 80.
Yeah.
So, that's 30 some odd years of your life that you're living without hormones.
Yeah.
You want to live a good quality life. So
before all of this, right?
Before
your hormones decrease, like you want to live a healthy life before, or do you want
do and after, right? You want to have a good quality of life once your hormones have, dropped off too.
Yeah.
Right? You don't want to be dealing with, cognitive decline and cardiovascular disease and all of those types of things. We want to live robust golden years, right? So there's a lot to think about once the hormones go away too.
And I feel like these conversations are very important, right? Because it's like taking it back to when we started our periods, like some of us didn't really know anything about it.
Yeah.
We were just having our baths and then we saw blood and we were terrified.
Right.
Now imagine if you take the same energy into your menopause stages where it's like your period just stops. I mean, I've heard stories about like heat flashes and stuff. Like I have an aunt, she has like a fan in her bathroom because like when this flashes starts, she just goes mad.
Yeah.
And it can be scary if you didn't like equip yourself with any knowledge about things like this.
Right.
So advocacy is very important, and you're doing great work,
Thank you.
sharing these things because people need to know, women need to know, because if you know, then you're a little bit less scared.
Absolutely, right? And it's no different with, like you were saying, with that menopause experience. I think there's been that's been a taboo topic too, right? And now people are finally starting to speak up about it, and they're learning that there are options. We don't have to go through that time without management, right? There's so much that can be done to help
manage
you feel better.
Really?
Absolutely.
Wow.
Right? Speaking as someone who is, well into that process.
This is so comforting to hear.
Yeah.
Because,
good.
Because it's been a little scary because I'm like, I mean, I feel like I don't know, but in my experience, quite a lot of people are scared of like growing old or like aging. But it's kind of like the opposite for me. I love it. Every time I turn a new year, I love it because I don't know, it just comes, I feel like it comes with some sort of like wisdom and confidence. And so I don't get what people are scared of, but when I think of menopause, I'm like, it's a little scary.
Yeah, and I think, you were spot on when you mentioned, just getting the period and being kind of freaked out. I mean, who isn't? But we're so kind of young and naive when that occurs that we don't know to fear it beforehand. When we're going into menopause, we know a lot more typically, and it is something that we can worry about, right? But it is kind of the exact other side. It's like going through puberty all over again, but in the other direction, right? And so I think the important thing to know is that you don't have to go through it alone, and there are options so that you can be properly cared for. And everyone experiences it in a different way. Just like everyone experiences puberty in a different way, everyone experiences menopause in a different way too. I was at an event last night with a number of women who were, I would say average age 50 and above. And some were talking about how they went through menopause and didn't have a hot flash, right? Others were having hot flashes as we were having the conversation.
Oh my God.
Right? So it's a different experience for everyone, but we can manage it. We can look into, are there other issues going on that could be making it worse? And then, of course, we're always going to come back to the wellness conversation, right? Are you eating well? Are you taking care of you? Because that's going to be paramount when we're going through any health journey.
So are there any fertility tricks that I can do to boost my chances of maybe having twins or like selecting the sex of my babies?
Yeah. Oh my gosh. I can't speak to those with any sort of like, validity, really. It's not like anyone's really researching those things.
No.
You'll hear all sorts of old wives' tales on the internet about if you're in this position or if you try to conceive at this time in the month, then, maybe it'll up your chances of having a boy or a girl but I can't really speak to those with any sort of like certainty, unfortunately. If I could, maybe I'd be a very wealthy person.
That's okay. I mean, all the while we've been talking about fertility and stuff, you've been saying take care of yourself, take care of yourself. What does take care of yourself mean?
Right.
Don't eat ice cream or...
No, ice cream's great.
Okay.
Don't eat ice cream every day.
Okay, fair.
Right?
Yeah.
It's an interesting topic. I take care of a lot of new Canadians in my practice, right? So people who are new to Canada.
Okay.
And I'm always so interested to see, what has changed for those people since they've moved to Canada. And in a lot of cases, they've found that their diet has significantly changed. Their activity level has significantly changed. And so, that to me is just such a great example of these factors that can so heavily impact fertility, right? It's unfortunate, but here in Canada, I mean, we have carbohydrates on every corner. And not the good kind, right? You can get noodles here. You can get donuts there. You can get a sugary coffee over there.
Chips, crisps, everything.
Everything. It's so accessible, right? And so we almost get a little bit brainwashed into thinking, well, it's there. It can't be that bad for me, right?
And it's cheaper too.
It often is, right? And this day and age when food prices are accelerating or increasing, sometimes that's what you grab for, right? So, eating well is something that's learned. It's a skill. And that is important for, optimal health. Getting enough protein, getting the right kind of protein, right? Not the kind that's full of saturated fat. Getting adequate vegetables and fiber, and choosing the right carbohydrates, not the refined ones, right? The grains, the ones that are packed full of fiber and nutrients. I mean, it's basic stuff, but when we're bombarded with crap, it can be hard to make those correct decisions. And if we were never taught those skills, which a lot of us aren't, then we may not know. So nutrition is key, movement. I always say to my patients, fertility loves blood flow. How can we get your blood flowing? Sitting on your ass all day, pardon my French, is not blood flow. Let's get up and move around, right?
And you know what's crazy is when I started working out consistently is I realized that you don't even have to do much.
You don't.
Like just like easy things on the treadmill, lift a little bit weight here and there. It gets everything. But again, I'm saying it like it's easy. It took me a while before I got onto it.
Yeah.
So I actually was copying my husband. He comes on with all these things, and then I eyeball him for like a year, and then I catch on. The same thing with like healthy eating. I find myself now before I drink like a juice or something, I'm looking at how many grams of sugar does this have, and it's just a little. I've become my parents. I've become my parents because why am I looking at how much sugar is in this? But it does take a lot of work. But how I see it now is, sometimes it's like the healthier foods are expensive, right? And so you just buy like the unhealthy ones, which is even more delicious in my opinion. But it's like you either pay the price now or you pay later.
100%.
And it's even worse paying it later because then you pay money and then you'll be sick as well. So just do it now when you have like optimum health and stuff like that. This has been a really insightful conversation. I'm trying to see if I haven't left out anything. So I'm just gonna ask, is there anything that I haven't asked you that you feel like people or women should know?
I don't think so. I think we've covered a lot. Yeah, it's been great. I'm so happy to share this information.
Thank you. And I've learned so much. And I'm so excited about the prospect of how many women will watch this and just know that they're not alone, and and that there's always help.
Always.
Just reach out, and not necessarily come on the internet and say, oh, this is what is happening. Just maybe find like a trusted friend or like go to the hospital.
Get a trusted doctor,
right? A doctor,
health advisor, right? Like, I mean, I'm sure you have a wide audience, but I'm part of a team called Conceive Health. And there are 17 of us that help, people all across the province when they're trying to conceive. We're all within fertility clinics. So if patients are needing that avenue of care, it's available to them, right? So it's just a matter of reaching out and getting some guidance, and we can get things moving in the right direction. We don't have to live in fear. We don't have to live in the shadows and try to do this all by ourselves. And really,
I don't even think we're supposed to do it all by ourselves.
We're not.
Excuse me. And what I've realized sometimes is we think an issue is big, but now I'm speaking from personal experience, right? Every time I open my mouth and talk about it, it's almost like it was never even an issue, because you find somebody who says, oh yeah, that it has happened to me before and this was what I did. And you just feel better. And if you need help, just open your mouth and ask.
There you go. I like it. You said in one of your podcasts recently, if I don't open my mouth, I won't get paid.
No, I have to open my mouth so that I can eat.
Exactly. Or maybe it was, so in this case, it's if you don't open your mouth, then you can't get help. Right? So,
and I know that it can be difficult sometimes. Maybe there are various reasons why people don't speak. Sometimes even from traumatic experiences.
100%.
Because even speaking personally, I kind of had, I find it difficult to ask for help, right? I don't know how to ask. I recently had to start learning to do that, because I realized that if I wanted to, I feel like life more is about people helping people, right?
100%.
Somebody taking a keen interest in you, and it's oh yeah, she can do this, and then she can do that. You're not necessarily like a burden, which is what I used to think of whenever I thought about the idea of asking for help. It's oh my God, I don't want them to see me. But now I'm realizing that the worst you get is no. And then you move on to the person who will most likely say yes.
You got it. That's great.
Thank you so much for your time. Welcome. This has been one of my favorites.
Oh, good.
Yeah, because it's women's health, and it's somebody's going to watch it and obviously be better for it.
Yes.
Thank you.
Thanks for having me.
Yes.
It's been a pleasure.
Yes. Thank you guys, and that's going to be all for now. Until next time, it's bye-bye.